Let's say your loved one just had an event and ends up in the hospital. Then she goes into a SCIF, skilled nursing facility. Then what? What's the discharge process? Do I need a social worker? What about a PT, an OT? All I want to know is how can I get mom back home? My name is Ryan Hurd. I am the founder of Caregiver Smart Solutions. We're going to answer these questions and a whole bunch more. So stick around and here we go. Hi, I'm here with Louisa DelCorpo. She is a social worker and she's been in the industry for 22 years. Louisa, how are you doing?
I'm doing great, thank you.
Excellent. So hopefully I got your name right, because
Yes.
It's definitely an interesting name. Can
Yes.
you tell me a little bit about yourself? You've been in the industry for 22 years. Like, where'd you start? Where'd you come from?
Sure. So, I love this industry. I started off at Hackensack University Medical Center. It was my, first job, but before that I was a stay-at-home mom. I started off there. I worked there on the cardiac floor for about 7 years.
Okay.
And then I also transitioned to other units as well. So I really, enjoyed working with mainly the geriatric population, I realized after working at Hackensack.
Okay.
So that's where I got my start, really, was Hackensack Medical Center.
So then you go from that, and now you're
Yes.
predominantly in the aging. So let me ask you a question real quick, because there's a lot of things that I'm learning as I go into this section of life. Why do we call it geriatric? What exactly does that mean?
Well, the first thing I think of when I mention geriatric population is the elderly.
Right.
Those people that are above age 65.
Okay.
But we are seeing a lot of younger patients, coming into our skilled nursing facilities, which is where I work currently. A lot of folks, we used to see, folks primarily in their 80s, 90s. Now we're seeing folks coming in that are, 50s and so forth.
Oh.
But geriatrics, there's the elderly,
Right.
is how I would define it. Yes.
Our aging loved ones.
I wouldn't define it as an age. I wouldn't put an age on it anymore. I used to, but not anymore.
Things have changed.
Yes.
Well, I wanted to interview you because what I'm learning is when we talk about caregivers, number one, nobody calls themselves a caregiver, right? It's the industry that's calling the person the caregiver. And what I
Yes.
found out, especially from my own personal situation, whether it's through, my grandmother who's 95 or my father that had cancer, is you're kind of thrust into it. So the scenario is an event happens, our aging loved one ends up in the hospital. Let's say she gets taken care of. She goes into, and I just heard this, a SNF. So
Yes.
a SNF is a skilled nursing facility.
Yes.
And then from there, you're bombarded with a bunch of things, right? You've got social workers, you've got OTs, PTs, you're talking about a discharge, something or other. And all I want to do is I just want to get mom home. So can you just go through the process of what happens when an event happens, mom ends up in the hospital, and then she's taken care of, but then what? What happens here?
Yes. So, so would you like me to start off as she's being discharged from the hospital, or once she enters the SNF?
Once she enters the SNF,
Okay.
skilled nursing facility.
Skilled nursing facility. Yes. So once the patient enters the skilled nursing facility, typically within the first 24 hours, they're evaluated by the team. So
Okay.
they'll be evaluated by the nursing team. They'll be evaluated by the therapy team. And very, very quickly after that, there's a treatment program or a care plan that's developed. And that's, very crucial to how things will progress in the skilled nursing facility.
Okay.
So within, like I said, first thing, 24 hours, the team evaluates the patient. Then the team also does what's called a 72-hour meeting. Okay. And that meeting is crucial. That's a meeting that's spearheaded by the social worker of the skilled nursing facility, typically the director of social work.
Okay.
And that's a meeting where the director will contact the family. And if the patient is alert and oriented, the patient would definitely be involved in that meeting. And as well as the therapy team and a representative from the nursing team as well. so we can encompass, the total treatment program.
So you have a bunch of people and you guys
Yes.
are looking at things from a physical level to a
Yes.
cognitive level, and then you're figuring out what type of treatment. I'm presuming that the physical treatment is a little easier. Mom broke her leg or her hip, and there's specific things that you have to do for that. But then there's all of these other things. And what are
Exactly.
your goals? Are your goals to get mom back home or figure out what's going on? What are the goals?
The goal is to really have the patient move towards being in a setting that's, the least restrictive environment. I mean, we want to promote quality of life. We do understand that, of course, everyone wants to go home. Everybody would love to be in their own home. In
Right.
some cases that can happen. In some cases it cannot happen for a variety of reasons. But our goal is not, to, it's difficult because I know a lot of folks and a lot of representatives and patients would like their loved one to be just as they were before the incident. And in a lot of cases that can't happen. In a lot of cases, patients need a little bit more help than they did previously. So it's very, very important that initially when we have these 72-hour meetings and so forth, that we get to know from either the patient or the representative what the patient's baseline was. How was the patient functioning before the incident that brought them into the hospital and the skilled nursing facility?
So is that where you're going to start asking, whether it's the family or the patient, like
Yes.
what happened to figure out, was it the dog ran in front of mom and she just tripped on the dog, and for the most part, she's fine, and you just got to put her through PT and get her back home? Or, is this a reoccurring event? She's been here 3-4 times and there's a cognitive issue as well as a physical issue. Is this the point where you're looking at that?
Yes, it is. Because all of those things, as you just mentioned, can affect the overall outcome. So if this is an isolated incident, a freak accident that happened, as far as any other, past medical conditions, really non-existent, then we're looking at somebody who's, kind of, in our world, an easy situation, get them some rehab, maybe some outpatient rehab when they leave, and all should be good.
Okay.
But unfortunately, we don't get a lot of those situations. So we really have to look at, the past medical history. We have to look at, what the patient's exactly, how many occurrences have happened. Is this a first time fall? Has the patient been falling multiple times? And if that's the case, we also want to examine the home situation, because the patient may be falling because no fault of their own. They may be falling because they have, throw rugs all over the house. They may be falling, for a lot of different reasons. So it's real important.
It seems like everybody in the industry hates throw rugs. I've heard that word,
Yes.
those 2 words from OTs.
Yes.
Every single time I have an interview. Throw rugs, for anybody watching,
get them out.
Throw rugs.
Yes, get them out.
Okay.
Yeah.
So what else are you looking for? So you're interviewing mom and or the family to try to get an idea of what's going on. And you're looking into their past history. Have they been here 2 or 3 times? What other things are you looking for to make your decision on, okay, do we go for trying to get mom back home, and what's the criteria? Or, what, I think she's going to have to go into a CCRC, whether it's assisted living or independent living or nursing home. Like what are the factors in that decision?
Well, that's a great question. A lot of different factors. So one of the factors we look at is the support system that the patient has. Okay. So that's one of the factors. Does the patient live alone? Okay. Does the patient have family that they live with? Does the patient have family that lives nearby that could provide, anywhere between 4 to 24-hour care if needed? Does the patient have neighbors that are supportive? So we want to know what the support system is at home. The other thing we want to know, just being real, is the patient's financial situation. What insurance do they have? If they have insurance, do they have private pay funds? So if they, decided that they wanted to go home, and the home was safe for them, were they able to pay a 24-hour caregiver if needed in the home, which can be costly. So we look at all of those. We also look at the functional level, because to be able to be accepted into an assisted living, you have to be performing at a certain functional level.
I did not know that.
Yes, yes. So, assisted livings are taking patients who are, sicker and sicker, because that's what we're seeing, unfortunately. But you have to have a certain functional level to be able to be in an assisted living, and also your medical conditions. Patients with multiple, let's say, just as an example, multiple stage 3 wounds. That's something in a lot of assisted livings, not all of them, but in a lot of them that, they would not be able to handle that acute level of care nursing wise. So there's a lot to look at, but definitely the support system the patient would have at home and their financial situation.
And that makes sense, because if that person has support, whether it's from family, whether it's from neighbors, or whatever, as well as a financial ability. And the financial ability it could be results of, how do I modify the house to make it easier to live in place?
Exactly.
Or, can I afford to have a 24/7, or even a, in-home services, somebody like a visiting something to help mom out. Now, there was a very interesting thing when you talk about physical abilities. There's something that I was speaking with a PT about, and one of their goals is to, if they can, get that person to be able to walk at a 2-mile-an-hour level. And that was very interesting. And I was wondering, why 2 miles an hour? And then what he said was, it's because when you look at the United States and you look at crosswalks and lights, all those lights are set for about 2 miles an hour. So if mom can walk at about 2 miles an hour, she can actually cross the road. That's fascinating.
I never knew that.
Yeah, I never knew that either. But it's interesting in where one of your goals is to get them to have that mobility.
Yes.
So they can function, whether it's in their home or even in an assisted living facility.
Yes. Another thing is, to your point that I've heard a lot of PT and OTs mention is, we'd like to get the person to be able to walk household distances. So that's another thing they would ask the family or the patient, do you know approximately what the distance would be from your living room to your kitchen, from your bedroom to your bathroom? So those are key points to make when you're working on a plan as far as therapy is concerned. Can we get this patient realistically to be able to walk with a rolling walker, household distances? So that's important.
Again, one of the reasons I'm doing this is because usually what it seems like is when we're talking about our aging loved ones in healthcare, it's very fractured. Let's face it, as Americans, we never believe that we're getting older. We don't believe that we need a little more help, right? We always want to say we're 29 years old, which is great. I'm never changing, although I'll be 50 this year, which is great.
Yeah.
We don't want to believe that we need help, but as we age, we do need a little more help, right? So when you get into this situation, do you have any suggestions for, let's say, the family as they're looking at this? Is there anything they can do to prevent? So get ahead of things, whether it's physical in the house or financial or insurance. Is there something they can do before an event happens that's going to have a better outcome for mom?
Yes, 100%. And that's something, unfortunately, I try to promote when I speak to families. Sometimes when I get to them, it's a little bit too late at times, but it's very difficult for families to think of that and for patients to think ahead of time. So what I would tell them is, as far as the house, let's say, the first thing I think of is if a patient is in a home with multiple steps, try to think about maybe moving to a condo or moving to a home. That's one level. So that's very important. That's very important to think about. Even, if you're thinking of moving, not to depress us, but in our 50s now, if we're thinking of making a move, if I was thinking of making a move now, I would really try to get a home with, limited stairs. Because that's something that patients struggle with all the time with discharge planning. Very difficult to discharge somebody with functional deficiencies that have multiple stairs at home, so that's one thing. The other thing I would do is to look at mom or dad's finances. Would they be eligible for Medicaid? Medicaid would open up a whole slew of services open to them. Medicaid pays for a nursing home. Medicaid could pay for a lot more in the way of a home health aid. But there are, financial criteria with that. So start looking at that. What does mom or dad have in their bank account, savings, so forth. Would they qualify for Medicaid? Would they maybe be able to spend down their assets in a facility, or spend down their assets using, a home health aid? Also saving all of your receipts, because if you are eligible for Medicaid and you are spending down, as they say, with your home health aid or spending down toward your care, Medicaid wants to see that, but they want to see all of the receipts that you're doing so. So that's
They
important.
want to see that the money's running out.
Yes, exactly. Exactly. Right. Yes.
Now, that's interesting. Is there a sweet spot at where we should start having this conversation with our parents? Is it like, the first time that I've noticed, let's say it's almost Easter right now. So when I see my aging loved ones and it's the first time I realize that, maybe mom or dad aren't as, quick as they used to be, is there a sweet spot that we should start having this conversation?
I mean, really, I would say that, we all should be looking at this, really, even at our ages. I think we should really start looking at this. There's really no magic age or magic time. I mean, for sure, 100%, if you see your mom or dad, are starting to slip a little bit, maybe if it's just, a 10% slip there, 100%, you need to start having that conversation immediately. But in a wonderful world, we should be having that conversation with ourselves right now, at 50, just to prepare, because you never know.
So just doing smart things, like as
Yes.
we're getting a little older,
Yes.
and our kids are getting a little older and moving out and experiencing the world. When we talk about that whole downsizing thing, keep in mind that we're downsizing for the future, for the next 50 years.
Yes.
So maybe look at a house as one floor that doesn't have, steps. Make sure that we get rid of all the throw rugs.
Rugs.
And hate throw rugs.
And if there are steps, make sure they have, the steps have handrails on both sides. That's important as well. So there are little things that folks can do, even now. I mean, I still consider us young, but even now there are little things we could do. But for sure, as soon as you start seeing, mom or dad, that really kind of something's changed there. You can't put your finger on it, but something's a little different. I would definitely start looking into that. They also have geriatric care managers out there that can help as well. They have elder care attorneys that can help as well. And you could use those monies that you're paying the attorney toward the spend down for Medicaid if you're eligible.
So it's kind of like putting a strategy in place, knowing that, my aging loved one she's getting older, or he's getting older. He's having a little more hard time. Maybe an event already happened, so I'm worried about an event happening again.
Yes.
What is the family going to do? What are we going to do for mom and dad to make sure we have the best possible outcome going forward?
Exactly, because all of this takes time. So we definitely don't want to wait until the event has happened and it's we're in an acute stage. Because all of these services, Medicaid services, they all take time to put in place. So, it's the worst thing to do, which a lot of people do, is to wait for an acute situation to happen where you're in an emergent situation.
I want to go back to one thing. You had said two words. It was a discharge something. When you're discharging a discharge plan, I think it was called.
Yes, discharge plan, care plan.
So what exactly goes into that, and who has the final sign off?
Good question. So I'm ultimately the final sign off from a skilled nursing facility would be the attending physician.
Okay.
So yes, so the team, and a lot goes into the discharge. So, we look at where the patient is functionally, where the patient is medically. We also have to look at, unfortunately, the insurance the patient has. If a patient has managed care insurance, the managed care insurance would like updates every so often. And really the managed care insurance would be the ones deciding on why are we paying for a patient to stay in the skilled nursing facility? Are they making functional gains? Are they making gains medically? Could these services be taken care of in the home? If they feel that these services could be taken care of in the home, they're going to give a last covered day at the skilled nursing facility, or essentially a discharge date. But ultimately, it is that attending physician in the skilled nursing facility that would make the final call and sign off on the discharge order.
So the team would get together. So an event happens, mom goes into the hospital. Then she goes into a skilled nursing facility, which you guys evaluate her based on what happened in the past. You have a conversation with the family at a couple of days later, and then you start working towards, whatever that result is.
Yes.
Then at some point you have this discharge, and that's another meeting of the group saying, okay, so we're here.
Yes.
What's going to happen to mom? I don't see enough. I don't think we're going to be able to get enough response or quality out of her. So she's going to have to go this way, or I think she's going to be good. And if she does X, Y, and Z at home, we'll be able to do that. Now, is a discharge, is that a I have to do or a you should do? I don't know about you, but my experience with my aging loved ones, especially my 95-year-old grandmother, she tends to be a little, I don't know what's the word.
I think
very nice young lady that is very opinionated.
Yes. Very strong-minded. Yes.
Strong-willed, strong-minded.
Strong-willed, strong-minded. Yes.
So is this
set in her ways? Yes.
Set in her ways, aren't we all? So is this a she has to do or a recommendation?
Well, as far as the discharge plan that we're recommending, it is a recommendation. It is highly recommended. Especially if a patient is, not alert and oriented, their loved ones really have to be the ones to say, yes, we are going to take your recommendations and we are going to move forward with them. We really try to help families and patients understand that, we are the professionals. We are here to help your loved one. And these recommendations should definitely be taken seriously to prevent another event. And in a lot of cases, what we also do is a follow-up. So after the discharge, within 24 to 48 hours the most, we like to follow up with the patient at home and the family to see, hey, how are things doing? How are things going? I'm sorry. Did you make an appointment with your primary care physician? That's important. Did you make a follow-up appointment with your primary care physician? Did you do X, Y, and Z? Did the visiting nurse come out yet? So that's important as well, the follow-up afterwards.
So that's interesting. So really your goal or the team's goal, and again, the team is everywhere from the physician to the social worker, the PT, the OT, everybody that's in the skilled nursing.
Yeah, speech therapy.
True. So your goal is really to get her up to snuff really as quickly as possible. Now, some people it's quicker and other people it's longer, but really your goal is to get mom as whole as she possibly can, as fast as she possibly can, and then hopefully into her own home. But sometimes that doesn't always happen. And there's alternative relative to funds available or, her support system.
Exactly.
Where she can go. So when a consumer, when a family member meets you, they really shouldn't be, worried about it. They should understand that, listen, we understand an event happened. It's very stressful. A lot of times it's very chaotic, but you and the team are there to help the family.
Yes. And the social worker, that's why I love my job so much. It's, very fulfilling, and I love to navigate folks through this system because it's very stressful. There's a lot thrown at you, a lot of information thrown at you. But the social worker, the director of social work at the skilled nursing facility or the SNF should be your point person. They should be your go-to person at that facility.
So that's the person that you ask all the questions, and they're more than happy to help the family understand what's going on and what is the process.
Exactly. And if they can't, answer specific questions, they would facilitate you to the right person that can answer that question. If it's nursing, if it's the doctor, but they are definitely your point person.
That's best. Well, listen, I really appreciate your time because you've definitely helped open up that sometimes people think it's a curtain, what's going on back there, you know, and again, as we said earlier, when an event happens, it just turns out to be a very chaotic situation. So I really appreciate that you coming on and talking about what happens and the team and discharges and all these other things. So Louise, thank you very much for being on. I appreciate your time.
You're welcome. Thank you.
Here we go. Have a great
day. Thank you. Take care.